All right, everyone, good afternoon. We're at the top of the hour. My name is Lynn. I'm one of the CityMatCH staff members, and here with me today also from CityMatCH is Denise Pecca, our Deputy Director. Now, before we get started with our webinar this afternoon, I'd like to first thank you for joining us. And then I'd also like to go through some housekeeping. So as you notice, we're using Zoom webinar right now. And so there's a little bit different in the functionalities. At the bottom of your screen, you'll notice that there is a Q&A button. And throughout the Q&A or throughout the presentation, if you have any questions that you'd like to submit to Dr. Warren, feel free to make use of that button. And then at the end of the presentation, we'll have time for questions and some discussion. And yes, this webinar will be recorded, and I'll upload it to YouTube and send it to everyone who registered using that data from the registration list. Now, without further ado, I'd like to pass it to Denise Pecca to lead us into the next part of the presentation.
Thanks, Lynn. Again, good afternoon. For most of you, it should be good afternoon. We want to make sure that we acknowledge some of the key folks from MCHB who you see on the screen right now that have been very much involved with this. There will be also recognition later of a planning committee that we will also give a shout out to. They will just smile and wave when I introduce them. Ellen Volpe, she's the Eastern Branch Chief of the MCHB Division of State and Community Health. Kathy Best, Regional Project Officer and MCH Consultant for Region 5 of the MCHB Division of State and Community Health, Eastern Branch. Sarah Henneke, Public Health Analyst of MCHB Division of State and Community Health, Eastern Branch. Vanessa Lee, Infant Mortality Coin Coordinator, Division of Healthy Start and Perinatal Services. Ashley Harai, Senior Health Scientist, MCHB Office of Epidemiology and Research. And Tamara Cox, Regional Administrator, Region 5, Office of Regional Operations in Chicago. Great. All right, thank you all for being with us. I am now going to introduce the star of this webinar, and you'll see everybody else start to disappear. Dr. Warren's career in public health clearly demonstrates his passion and commitment to improving maternal and child health outcomes. And I would give as evidence the very fact that we are starting this webinar series with the hope of, with the expectation that we will see improvement in maternal and child health. That was my own little bit. Before assuming his current role at MCHB's Associate Administrator, Dr. Warren served as the Deputy Commissioner for Population Health at the Tennessee Department of Health, where he made improvements in maternal and child health across the state. As a board-certified pediatrician, Dr. Warren previously served as the Tennessee Department of Health Assistant Commissioner for Family Health and Wellness and as the Director of Maternal and Child Health. He has served as President for the Association of Maternal and Child Health Programs, MCHB, the National Professional Organization for Maternal and Child Health Professionals. With that, I'm going to turn it over to Dr. Warren for his presentation. Thank you.
Thank you so much, Denise, and good afternoon to everyone. It is so exciting to join you all. This has been a labor of love, and we'll talk a little bit about that as we talk about the evolution of this. But I have shared with folks, it was hard to sleep last night. This is like the night before Christmas, and really kicking off something that is so exciting and frankly so long overdue. And we're just grateful to be able to partner with CityMatCH on this and to move this work forward. This kind of thing doesn't happen with one person, and there are so many people to thank for this. So I do want to acknowledge CityMatCH. MCHB has had a longstanding partnership with CityMatCH. We value that relationship very much and their expertise in this space, and we're so grateful they are partnering with us on this work. You also got introduced to members of our HRSA team. I want to say thanks to our acting administrator, Diana Espinosa, for supporting our work at MCHB. You heard about numerous MCHB staff who are on the call. They really are the engine behind this and making this work and have done a fantastic job in preparing for this. We also are grateful to do this work in solid partnership with HRSA's Office of Regional Operations. So our Region 5 Administrator, Tamara Cox, who's on, and the director of regional operations for HRSA, Natasha Kaloris. They are tremendous partners in helping us to do this work. We absolutely know this work doesn't happen in Rockville, right? This work doesn't happen in DC. This work happens where you are. And so those regional connections, those state and local connections are so valuable, and we're grateful for that. There was also a planning committee, also is a planning committee, I should say, who's been working on this, and they've been working on this for a while. I want to acknowledge the tremendous work that they have done in helping us to think through this and how to do it right and who to engage and how to engage so that we can, as Denise said, make this happen. This is not a we want to, this is we're going to, and we're going to figure out how to do that with you all. I do want to call out one person who's been on that planning committee who has been an inspiration to me and others long before that planning committee, and that's Dr. Arthur James from Ohio. I first got to hear Dr. James when he came to Nashville back when I was working with the state health department there, and he came to do a consultation for the city on how we could address infant mortality. And if you've ever been around Art, you are immediately struck by his deep passion and conviction for this work. And you also feel this sort of deep yearning in your soul where you have to do something. You've got to move forward. We can't stay where we are. And so I want to thank Art for the many ways he inspires all of us every day, and for really being an inspiration for this work and calling us forward to move ahead. So with that, we are going to dive into the webinar. I'm going to share my screen with you, and we'll dive into some slides. So those are visible. The topic for this is accelerating upstream together to eliminate infant mortality disparities by 2030. So why are we here? Well, as is no surprise to all of you, there have long been disparities in infant mortality in Region 5, really some of the highest in the country, and they have been persistent, and those are unacceptable. As a Bureau, we are absolutely committed to accelerating progress to eliminate those disparities. And so a planning committee has been thinking about this for a while. We had actually hoped to bring you all together for an in-person meeting in the region last year. And as you all are dealing with every single day, we've been navigating the COVID pandemic as a country. You all have been doing that at the state and local levels. And so it just wasn't appropriate, wasn't safe, in fact, to bring us together in person. And so the committee took a bit of a pause at first, but then regrouped and said, what can we do and how can we do it? And so the plan was to come forward with this virtual meeting to kick off what will be a year-long series of learning webinars where you can learn together that will ultimately culminate in an in-person meeting. We will be all able to travel again one day, and we'll come together and move from talk to action. And that's really what we want to think about. The hope is that these meetings will really support us to have a shared understanding of the root causes of disparities in infant mortality and allow us to engage a larger group of stakeholders. There's a bit of a blessing in not being able to travel. We can actually get more people into these virtual meetings than we could in person. And so it allows us to cast our net more broadly and be able to engage those community partners. As I mentioned, our goal is to eliminate racial disparities in infant mortality by 2030. That is a tall order, but we wouldn't throw it out there if we didn't think we could do it and that you all could do it. So that is why we are here. Within the Maternal and Child Health Bureau, we use a paradigm called Accelerate Upstream Together to talk about how we do our work. And I want to walk you through what we mean by those three concepts. So we'll start with accelerate, and it's actually pretty simple. It means we have to work faster. If you think about infant mortality in the United States, even over the last 40 years, we've made tremendous progress, right? We've cut our rate more than in half. And so that is great. And we celebrate and we say things like, we've achieved a rate of 5.6. That is certainly noteworthy when you look at the trend over time. But what does a rate of 5.6 actually mean? Well, if you translate that into actual numbers, that equates to almost 21,000 babies dying every year before their first birthday. And I want you to think about that number for a minute. 21,000. You know, a lot of times in public health, we talk about rates and percentages and really large numbers, and it can be hard to put that into context. So I want you to think about something that we all are familiar with, an airplane. And this is a jumbo jet that happens to carry about 400 people. Now, imagine if that plane crashed. What would happen? There would be an investigation. There would be all sorts of news stories. There would be a lot of attention into what went wrong and what could we do differently. Now imagine instead that that plane crashed, or a plane like that crashed once a week for 52 weeks in a row, an entire year. We would stop flying in this country. There would be task forces. There would be all sorts of inquiries. There would be a massive cry for, we must do something different. We have to change what we're doing. And yet we lose as many babies every year in this country as is the equivalent of what you see on your screen here, a jumbo jet crashing once a week for an entire year. That's not acceptable. And even as we celebrate the fact that our infant mortality rate now is half of what it was 40 years ago, we have to do better. We have to accelerate our pace of change. Now, we can't just stop by looking at that overall population number of 5.6. It's really important to think about, how is everybody doing with regards to infant mortality and looking across populations? This is another one of those times where I want to give credit to Dr. James for helping us to think differently when we talk about disparities. You know, so often in public health, when we talk about disparities, we talk about rate ratios. So Black babies die at a rate 2 to 3 times that of white babies. And we say it so much that it almost starts to become routine, and it almost starts to lose really the meaning and the impact. And so Dr. James implored us to look at this differently and think about what it means in terms of the survival lag. And so I want to explain to you what that means. So if you think about in 2017, the infant mortality rate for Black infants was 10.8. That was the same as the infant mortality rate for white babies in 1980. So 37 years of a gap, a survival lag between Black and white babies. If we were to march that out over time and think about that rate of improvement continuing at the rate it's been in the past, and we think about where white babies were in 2017 and how long it would take Black babies to achieve that same infant mortality rate, it's even longer, 52 years. So again, speaking to the fact that we have to accelerate our pace of change. We can't wait 52 more years or 37 more years, in fact, for Black babies in this country to have the same chance of survival in the first year of life as white babies. We also know that those disparities persist for American Indian, Alaska Native populations. So a similar survival lag is shown here. If you look in 1995, there was a 10-year survival gap for American Indian, Alaska Native babies compared to where white babies were in 1985. And as we march that out over time, in 2015, that survival lag had extended to 26 years. And if we were to march that out and look at the 2015 rate for white babies and how long it would take American Indian, Alaska Native babies to reach that same rate, it's a 72-year lag. So again, I hope you feel this gnawing in your heart and in your gut that we have to do something different, and we have to do it more quickly. We must accelerate this pace of change. So how do we do that? That's all good and well to say, but how do we accelerate that work? Well, one way to do that is to think upstream. Some of you have heard this fable in public health about a person who's walking along a river, and it's a beautiful day and they're enjoying the calm and the serenity of being by the water, when suddenly that is punctuated by splashing and crying out for help. And so the person who's walking looks, and they look out in the river and there's somebody there who's struggling. And so they jump into the river and they swim out to the middle and they grab that person and they bring them to the shore. And as they're helping that person up onto the shore, they hear more splashing and more screaming and cries for help. And so they turn and look, and there's someone else who's struggling in the middle of the river. And so they swim out to the middle of the river and they grab that person and they bring them to the shore. And as they're helping them up, lo and behold, there's more splashing and there's more crying out for help. And so they look and there's someone else who's struggling. Well, about this time, they also see someone who's jogging along the riverbank. And so they call out to the jogger, "Hey, won't you help me?" But the jogger keeps going. And so the person who's been doing all this saving says, "Hey, why won't you help me? Why won't you stop?" And the jogger says, "I'm going upstream to see why these people are falling into the river in the first place." So much of what we do is oriented downstream. We take care of people once they get sick. But there's a great opportunity to do like that jogger did, to move upstream, to prevent illness and sickness from happening in the first place, and to think about primary prevention. I think there's another important corollary. When we think about structural determinants of health, it may not be that people are falling in the river. It may be that people are being pushed into the river. When we think about racism and bias and how that impacts the work that we do, we always have to be mindful of that. So our thinking of upstream really must be broad and include primary prevention strategies, but also social and structural determinants of health. So I wanted to share a few key concepts with you as we think about this work upstream. Many of you know in MCH, we talk about the life course approach, and life course says we all have this optimal health trajectory, and our ultimate trajectory is influenced by risk factors that can bring that trajectory down, or health promotion factors, which can bring that trajectory up. And where we ultimately land is really about a balance of all of those factors coming together. So those influences along the way, those factors throughout our life, shape our overall health outcomes. But life course is not just about that. It's also about looking at the influence of our health, how our health is influenced by the health of our parents and well-being and their well-being, and how our health will influence the health and well-being of our offspring. So when we talk about infant mortality, we can't separate the health, for example, of mom and baby. One of the particular interests of this planning committee has been to say, MCHB, don't give us another plan to do around infant mortality that's separate from what we're doing around maternal mortality and improving maternal health. You have to think about them together, and they are absolutely right. If we're going to improve infant health, we've got to improve maternal health. And tying this back to life course, we can't decide that we care about women suddenly because they end up in prenatal care or suddenly because they end up in labor and delivery. We have to care about women's health across the life course, so that as those young girls and adolescent females who are maybe seeing pediatric providers are being in the time of their life when those health trajectories are being influenced, we're setting them on an optimal path for health and well-being, so that should they choose to become pregnant later in life, they are as healthy as they can be when they enter that pregnancy. So that's life course, and really that plays an important role in the work that we do. If we think about that and what that means for birth outcomes, we've got a lot of opportunity for improvement in this country. If we look at women's health statistics, if we look at women's access to care around well woman visits, around women's health status, women who describe their health as fair or poor, women who have health risk behaviors like smoking, we know that we've got opportunity. But again, we can't wait until we get to adulthood to decide that we care about health. We have to look upstream and look at the health and well-being of young girls. How are we setting them on those optimal paths for health and well-being later in life? Because that, if we're going to think about influencing birth outcomes, we have to think that far upstream. Another important concept to think about when we think upstream is what actually determines health. So I'm a pediatrician by training. I've got clinical knowledge, but my time in clinical practice showed me that I have 15 or 20 minutes with a child and family in a typical visit. That's not nearly enough time to address or impact all the factors that are influencing their health and well-being. And so across a variety of studies, we've seen that health care, that clinical work, accounts only for about 10 to 20% of a person's overall health and well-being. Many other factors, when we take them collectively, things like health behaviors, the community, the environment, social circumstances, our genetic susceptibility, those collectively impact our health and well-being more than clinical care. So if we're going to think about health and improving health, we've got to get outside the walls of our clinics and our hospitals into the community and really thinking about some of these other factors. So we talk a lot about the social determinants of health. These are the factors that are in place where we live, where we work, where we play, where we worship, things like education, healthcare access and quality, the built environment, our social context, economic stability. All of those are important to influence if we're going to think about improving health outcomes. But we also have to think about structural determinants of health. So those are those factors that actually influence how we experience the social determinants of health. So those structural determinants, like our governing processes, our policies related to economics or social policies, Factors like racism, discrimination, bias, and segregation all play a role in how we experience those social determinants and lead to different experiences of those determinants. So whether we experience wealth or poverty, whether we have access to education, and what is the quality of that education? What is our access to employment opportunities? And the list goes on, as you can see. So when we think about influencing health, if we think about influencing infant mortality in this case, we have to think about social determinants and we have to think about structural determinants of health. The good news is states are looking upstream already. So some of you know we have the Title V MCH block grant program. It's the largest item in our Bureau's budget, and it really forms the foundation for the public health system for mothers, children, and families in this country. Every state and jurisdiction that's on this call gets a block grant. And one of the beautiful things about a block grant is that states get to tailor the work of that block grant to the specific needs and priorities of MCH populations in those states. Certainly the reality is that the needs of families and the priorities of families of states in Region 5 may be very different than in Region 10 or in Region 4 or in Region 3. But also the needs of kids and families in Minnesota may be very different than the needs of kids and families in Wisconsin or Ohio. And the block grant gives us the flexibility to meet states where they are and to be responsive to those specific needs and priorities. Every 5 years with the block grant, states do a needs assessment where they do this comprehensive look and engagement with MCH populations to better understand where they've got opportunities for action. And when we compare those 5-year needs assessments across time, we've just done one this past summer, many, many more states selected social determinants of health as a priority. So 42% of states in 2020 compared to about half of that in 2015. Similarly, 46% of states, almost half, selected health equity as a priority, up from about 29% in 2015. So states are moving in this direction. They are wanting to do this and to look upstream. Many are also acknowledging taking health equity and social determinants of health into the various frameworks they're doing as they approach their work. So 54 out of the 59 states and jurisdictions indicated that in their last application. So you're absolutely moving upstream in the right direction. So the last part of that framework is together. What does that mean? And I think that gets us to, for me, what is the most exciting part of the conversation today. My friend and colleague, Dr. Wanda Barfield, many of you know Dr. Barfield from the CDC, said recently, we're not there until we're all there. And so when we think about things like improving infant mortality, when we think about targets like the Healthy People 2030 target, those are great. And we might say we're there, but we should always ask that question of, are we all there? And if we're not all there, then our work is not done. So as we think about achieving equity in infant mortality, I like to start with that quote from Dr. Barfield. And it poses the question for us, what would it take to achieve equity in infant mortality rates by 2030? What would it take for us to be all there? Well, the Healthy People 2030 target related to infant mortality is set at 5.0 infant deaths per 1,000 live births. So that would be an infant mortality rate of 5.0. And so you say, okay, that's good to know. How are we doing on that currently? So if you look across populations, and you just to orient you on this graph, the red line going across represents the Healthy People 2030 target of 5.0. You'll see that some populations, non-Hispanic white babies, Hispanic and non-Hispanic Asian Pacific Islander babies, are already at or below the Healthy People 2030 target. So they've already met that target. But what you see very clearly here is that non-Hispanic Black babies and non-Hispanic American Indian Alaska Native babies are well above that target. This gets to this notion of there are marked disparities here. And as we were looking at this, we recognized that if we hit the target, that would be great. That would mean we had reduced infant mortality rates for Black and American Indian Alaska Native babies. But we don't expect that the other populations are just going to be static. We expect and hope that they will continue to improve over time. And so if we don't accelerate our progress for populations that are already above the target, we're going to continue to have disparities when we get to 2030. And remember, our goal is to eliminate that disparity by 2030. So we've got to do something different. This is where I'm so grateful that we have such brilliant people in the Bureau. You met a number of them earlier. They have such amazing talent, and a lot of the work you're going to see on the subsequent slides was done by Dr. Ashley Harai, one of our senior data scientists, who really has helped to make this very visible and real for us. So as we think about where we want to go from here, ultimately, we want to prevent every infant death possible. That goes without saying. We want to prevent every infant death possible. And given the large and persistent gap between Black and white infant mortality rates and white and American Indian Alaska Native infant mortality rates, we have to accelerate our efforts to achieve equity now in those populations. So I want to share with you some of the calculations and visuals that have been done to give us an idea of what it would take to get there. So if we look at a target of an infant mortality rate of 4.0, Dr. Harai ran the numbers, and if we project out to where white babies will be in 2030 in terms of infant mortality rate, it's about 4.0. So if we said, what would it take to get everybody there? That means we would need to prevent an additional 4,000 deaths among Black non-Hispanic babies and about 160 among American Indian Alaska Native babies. So just under 4,200 deaths a year that we need to prevent. Now, to put that in context, we have about 10,500 babies born every day in this country. All we've got to do is figure out a way to save 12 a day. So out of that 10,500, just save 12 more. There is no reason we can't do that in this country in 2021. And that's at the national level. We're about to show you what that looks like when you break it down at the state level. So as you all know, the rates are not consistent across the country. Certainly some states have higher rates of infant mortality than others. Some have higher disparities than others. And so we were able to map out what would it take to achieve equity in terms of the number of deaths that we need to prevent. And what you see on the map, the darker colors represent the states with the highest number of deaths that are needed to prevent. 3 states stand out: Texas, Florida, Georgia. And those 3 states alone, we account for 24% of all the deaths that we need to prevent. So if we think about how we engage this work nationally and how we move this work ahead, we know we've got some opportunity to target our efforts. But I want you to look at Region 5. You know those states very well because you live there. Those colors are pretty deep there too. So we've got multiple states that are in those deepest shades of red where those numbers are very high. So a lot of opportunity to really dive in and impact the work nationally by the work that you all are doing in Region 5. And we're going to show you some region-specific graphs in just a moment. So I mentioned the 3 states that account for 24% of all the infant deaths, but I also want you to look at the states that maybe are the lighter shades of colors. And if you look at the table on the right-hand side of this graph, we've broken this down by the number of deaths that are needed to be prevented annually and monthly. So in those first 3 lines, you see that we get about 38 states, so more than 2/3 of the states that account for about 30% of all the deaths. In some of those states, 15 of those states, we're talking about 1 additional death prevented per month to be able to achieve this goal. One death per month. Some of the states, the lift is a little bit higher, maybe even as high as 5 to 9. But again, when we think about breaking this down, this seems very doable as we engage our state and local partners to do this work moving forward. So that's the state level. If we look at the county level, we get additional data. So the blue dots here correspond to the size of the number of deaths that are needed to be prevented to achieve equity. So the larger the dot, the larger the number of deaths that need to be prevented. You'll see that in Region 5, there are a number of larger blue dots. Across the country, there are 3 counties that account for almost 10% of all the deaths that we need to prevent. 3 counties, 10% of all the deaths we need to prevent. So Harris County in Texas, and then in your region, Cook County in Illinois and Wayne County in Michigan. So a lot of opportunity, even in Region 5, to think about this work at the county level, again, influencing those national numbers in a big way. I also want to, again, talk about the counties where the lift is not very large. So if you look at the table on the right, the first 2 rows, 43% of all the deaths are in counties where we need to prevent one additional death per month. One death in a county per month needs to be prevented. You see that it actually says less than one. In some of those counties, the numbers are so small that we put it in the bucket of one, but it actually rounds to something less than that. So it may be one death every 2 months. Again, making the case that we can absolutely do this. So what does this look like in Region 5? So you see the map blown up here to specifically focus on your region. A number of states that have anywhere from 120 to 240 deaths a year that need to be prevented, some in the 60 to 120 range, and then one in the 12 to 60 range. You see over on the right-hand side the breakdown by states and how many additional deaths you need to prevent per month to achieve equity. So the lift is higher, for example, in Illinois, where there are 19 deaths per month that are needed to be prevented, than in Minnesota, where that number is 4. I would encourage us in all of these cases to go back to our stakeholders and say, what do you mean, Minnesota colleagues? We can't save 4 additional babies a month. We've got a whole state and partners working across the state to do this. We can save 4 babies a month. The lift may be higher in Ohio and Illinois, but you can do that too. The county data is also available. You can see here on the slides in the distribution of those counties. We can make this data available to you, provided that in some counties the numbers get really small and the data aren't reliable, but certainly where the numbers are large enough, we can work on providing this to you so you can help target your efforts. So if you think about the national picture and the map I showed you, it's important to know that 4 of the top 10 counties in the entire country where we need to prevent deaths are in Region 5. So Cook, Wayne, Cuyahoga, and Milwaukee counties are in that top 10 across the country when we think about the highest number of infant deaths that we need to prevent. So the maps and tables that I've been showing you have focused on non-Hispanic Black deaths that are needed to be prevented. We also wanted to share the American Indian, Alaska Native numbers with you all. Those numbers are smaller, but we know that that has been a priority and an area of focus for your region. And so those are shown here. 11 deaths needed to be prevented in Minnesota, 5 in Wisconsin, and 1 in Michigan. These are annual numbers. So again, really highlights the doability of this. This is doable if we put our minds to it. So you all are so well primed to do this already. I mentioned the needs assessments earlier, and the Region 5 needs assessments, when we look at those and pull out common themes, the top themes that emerged were neighborhood and built environment, community-based care, and those linkages between community organizations and clinical-based organizations, reducing disparities, focusing on transitions of care and social and community context. So if you go back to our conversation earlier about the determinants of health, you all are already on top of this. You're thinking about those, you're including those in your block grant priorities. And all 6 of the states in Region 5 chose measures that will address these areas of need. So you are already poised to do this, and we are excited to support you as we do this work together moving forward. I want to close my portion of the remarks with a poem. And this was written by one of the early leaders of the Children's Bureau, Grace Abbott, who was the 2nd chief of the Children's Bureau. And I hope you will find her remarks as inspiring as I do. Her speech was called The Washington Traffic Jam. And she said, "Sometimes when I get home at night in Washington, I feel as though I'd been in a great traffic jam, moving toward the hill where Congress sits in judgment on all the administrative agencies of the government. In that traffic jam, there are all kinds of vehicles, the kinds of conveyances, for example, that the Army can put into the street, tanks, gun carriages, trucks, the dancing horses of officers. There are other kinds of vehicles in this traffic jam, great numbers of them, hayricks and the binders and the plows of the Department of Agriculture. There are the handsome limousines of the Department of Commerce and the barouches in which the Department of Justice officials sometimes appear. I stand on the sidewalk watching it become more and more congested and more difficult. And then, because the responsibility is mine and I must, I take a very firm hold on the handles of the baby carriage and I wheel it into the traffic. We come from a long line of leaders who have been focused on elevating the causes of mothers and children and families and prioritizing this work. You are a vital part of that work. And so today it's time for us to move into the traffic. It's time for us to grab the handles of those baby carriages in our 6 states and across the country and to accelerate Upstream Together. I thank you for your time, for your commitment that you've shown to date, for the partnership that we will have moving forward. And I look forward to celebrating with you in 2030 the ways that we've achieved equity in infant mortality across the country. Thank you.
Thank you, Dr. Warren. I really appreciated all of your remarks, from the Accelerate to Upstream to Together. I thought it painted a very clear picture of the dire need in our field right now. So without further ado, I think we'll go ahead and move into some Q&A. We did receive a couple questions. The first one I think perhaps could be appropriate for you, Dr. Warren, or for you, Dr. Harai. Someone asked if there is a correlation between infant mortality and maternal mortality rates.
Well, if Ashley doesn't mind, I've been talking a lot. I need to take a sip of water. Ashley, do you mind starting on that one?
Yeah, I think there definitely is a correlation. I had started to look at that at the state level, and I think it was, above 50%. So there was a correlation. It wasn't, 100% by any means. There are a lot more infant than maternal deaths, and they don't always occur together. But there definitely is a strong correlation, as Dr. Warren said. Those maternal-infant linkages are incredibly strong, and were noted very early on, historically, at the start of the Children's Bureau as well. They were looking at those connections in different communities, looking at infant mortality.
All right, great, thank you. Here's another question about data for either of you. Is there a plan to disaggregate Asian and Pacific Islanders? Pacific Islanders have a higher mortality rate and poorer health outcomes as compared to other Asian subpopulations. Due to these differences, I was wondering if there was a plan to measure IMR or MMR for Pacific Islanders.
So I'm happy to talk generally about that, and then I'll defer to Ashley, who is far and away our expert on this. I think generally there is a need, and we recognize that need, to do a better job with data disaggregation. Whether we're talking about Asian Pacific Islander, whether we're talking about Hispanic populations, it's important for us to always get to as granular a level as we can, because we know even among those broad classifications, there are multiple other populations and the outcomes aren't necessarily the same. The desire to do that hasn't always kept up with our data collecting practice and capacity. And so one of the things that may come out of this work, as you all try to better understand what's the situation in your states and where you go from here, you may recognize there's a need to better disaggregate your data and work with partners on that. It may be that it already exists, it's just not in published reports. And so partnering with your state health department or county health department, your vital statistics folks, may help really get to a better understanding of various populations. But again, I think there is a general need to do that disaggregation more deliberately. Ashley?
Yeah, I would just add that we definitely have plans to do that. So we needed to use 3 years of data and Bayesian, this kind of fancy method, to smooth and get more reliable estimates at the county level. So we were using 3 years of the linked file, the linked birth and infant death file. And so when the 2019 comes out, and we have 2017 to 2019 to base those estimates on, that's when all of the states have collected and disaggregated single and multiple race, and we can finally split out the Asian and Pacific Islanders and really get to that. Because if you look at the latest linked report from MCHS, you'll clearly see that Native Hawaiian Pacific Islanders have high rates, as well as there's heterogeneity in the Hispanic population. So the Puerto Rican population also has very high rates. So we definitely plan to look at this in more detail as the data permit, and that is coming quickly.
All right, thank you both for answering those questions. So the time now is 2:41 or 3:41, depending on where you're calling in from. We actually did have some discussion questions that we wanted to go over with the audience. And so we'll go ahead and wrap up that Q&A. I'll make note of each of the questions that we have received and see if we can address them in a follow-up email afterwards. So I know there are some more questions about data and some aspects of maternal child health programmatic work. And so we want to give that its due diligence. But to see who we have in the audience here, the hundreds of people that we do have, because we're on Zoom webinar, we don't get to see your fabulous faces. We don't get to, interact in our usual Zoom meetings. I do have some poll questions that I'd like to pull up and see if I can get a read on our audience today. So for the first question, I'll go ahead and launch that right now. You should see it on your screen. If you could please tell us, what state are you representing? Let's see. We've got about 100 people left. And I know there's a handful of people who called in on their phones. Don't worry, we'll also ask this information again later. Okay, we're about 80%, and I feel like that's pretty good poll response rate. So I'll go ahead and end that right now, and I'll share the results with you. It looks like we have the most representatives from Ohio, but we do have people from each of the Region 5 states and people from outside of Region 5. So welcome everybody. And I see that Ohio rolls deep. Okay, let's see. Let's see, for the next one, can you please tell us, are you a community member? In other words, are you a member that would be considered a general person from the general public? Or are you usually affiliated with an organization? We do have some people from the general public. That's awesome. If you've worked with CityMatCH before, you know that we highly, highly value the authentic community engagement, because we believe that that's where the expertise is.
Awesome.
Okay, we'll go ahead and stop it. Let's see. So most of us are affiliated with an organization. That's perfectly fine, but we do have some community representatives. Okay, last question. Now, for people who are a part of an organization, could you please tell us about your type of organization? Are you with a state health department, local, an FQHC, a nonprofit maybe? Early results show we have a little bit of everybody. That's great. Okay, I'll go ahead and stop that and share those results with you. We have a lot of people from state health departments or state government agencies. That's great. Next highest, we have local health departments and nonprofits or CBOs. Fair amount of Healthy Start folks. That's awesome. All right, thank you everybody for engaging me in those polling questions. So today we've heard from Dr. Warren about accelerating our equity work. And Dr. Warren, I thought your metaphor of the planes made it so tangible. It's something for us to really grab onto in terms of imagining just how dire the situation is in maternal and child health. And then you took us through that metaphor of working upstream and what that means. And I thought your point about, there's people who fall in, but then there's also people who get pushed in. And I think that's very, very important to distinguish. And then you also talked about the importance of the life course theory. And then in the together part of your presentation, that the 12 babies a day, I thought, like, we have, we're in this dire situation, but just 12 babies a day, I think that makes it so much more achievable and so much more like doable. And so I really appreciated bringing that home. And so from the audience, given what Dr. Warren has shared with us today, we'd like to hear from you. What does moving upstream mean in respect to, maternal and child health or improving birth outcomes? What does moving upstream mean to you? And I've reactivated the chat for all of the attendees. So if you'd like to chat with us, here's your chance. And there's, at the bottom of your screen, you'll see that raise hand option. If you'd like to raise your hand and chat with us directly, go ahead and raise your hand and I'll unmute you in the order that I see them. Okay, so moving upstream can mean working with school systems. And it can be like with the education sector that Maureen is talking about. It could be with business, right? It could be collaborating, because public health wasn't, or, we didn't create health disparities on our own, right? It takes an entire system. So it makes sense to work with school systems, right? It makes sense to engage different sectors. What else does working upstream mean to you? Housing, yep, housing is important. Health policy, yeah, that's a big one. That's a very big one. Addressing childhood trauma and poverty early in life, yes, especially with respect to the life course perspective. That can have severe long-term impact on a person's development and their roles as parents, as caregivers, as people who have children one day. Exactly.
And we had a raised hand.
A raised hand, okay. Let me see if I can. Oh, it's gone. Okay, we did get some messages through the Q&A. Let's see, upstream can work like prenatal care, partnerships with physicians. Yep, public health didn't create health disparities on our own, and so it is important to work with the clinical and medical framework as well. Food and nutrition assistance programs, absolutely. Let's see, it means looking at new ways to address this old challenge in our communities. It means using technology better to meet those who are not connected to a system. Yes, 110% yes. Let's see, we received a comment that says, moving upstream means creating open channels for all local community resources, letting our experts connect with each other instead of competing. It's all for our community members. Yes, if I could emphatically, clap, applaud, all of that, yes, 110%, I agree with that. Okay, so we've identified all of these different ways of moving upstream and what that might mean for you and your communities. So how can we accelerate towards those upstream methods? How can we accelerate this work to achieve equity by 2030? What kinds of things would you like to see? Or maybe what kinds of things are you seeing right now that you think are innovative ways to move towards equity?
Lynn, we have a raised hand, so Angela, I'm
go
gonna
ahead.
open it up for you, Angela. Angela Dawson, you're unmuted. Okay, maybe that was accidental.
So we got a comment that says, focus on anti-racism work. Yes. I could go off on a soapbox about that, but I'll save that for another talk. Supportive housing for homeless pregnant youth. Okay. Jennifer, did you have something to share?
Yes, I remember Denise from CityMatCH when I worked for the Butler County Health Department.
Oh, hello, Jennifer.
I'm thinking that you're the one.
Yeah. Yes.
You are. Okay, okay. And I said in the chat that I didn't see much progress. One of the things is I am a community health worker. And so we had a grant, but the community health workers aren't as, they're not going into the field. And why they're not going into the field, I'm not sure. And I think that when I was a community health worker, when I was a practicing community health worker, we knocked on doors and said, do you have anyone in here that's pregnant? We went to the schools, we went different places and seeing now that's not happening. And transportation to doctors, you know, a mother with 3 and 4 children trying to get to an appointment, no one to babysit. So I think my biggest thing is transportation. I think that's a real big issue for pregnant women, for women in certain neighborhoods, having to walk to the bus stop. So go ahead.
Great. Yeah, thank you. Great. We've got that captured. You're absolutely right. You actually hit on 2 key pieces, right? The community engagement and authentically, truly having community be part of this and informing this work all along the way is critical. And then transportation, as we know, is a challenge and a barrier. Thank you.
Mm-hmm.
Looks like we have a couple other raised hands now. Joy? Joy, I think you're unmuted. Lynn, does it look like Joy's unmuted? No.
I asked Joy to unmute. While we wait, we did receive something in the chat that says new ways include breaking down the MCH silos across states, find ways to work together, state health departments, CBOs, to better address these issues. Yes, absolutely. Joy?
Hi. Actually, my name is Ada, so I just received the invitation from my boss, that is Joy. Yeah, so I am bilingual community worker though, and we're still going to the field. So at this moment, we don't because the COVID, but before COVID, and I hope after that, we're still going to the field and knocking doors. And we do outreach, we do canvassing and all the stuff. We go to the stores. Yes. We still clients. Yes. Thank you.
Thank you.
Heidi, did you have something you'd like to share?
Sure. Just like I think she said her name was Asia, something like that, the one that just got done speaking. I work for Resource Mothers in Youngstown, Ohio, and due to the determinants of health, we know that transportation is an issue. We have 2 vehicles that are unmarked, SUVs, and we just purchased a 12-passenger, passenger van to be able to transport. But because we are beneficiaries of a Medicaid grant, and when we did request funding for transportation, I guess because they do provide transportation, but it is not good for the girls the women to have to wait for so long for the transportation to either take them or come back in and pick them up from the doctor's appointment. It is easier for us to drop them off. That was the issue. And so they rejected the proposal for the transportation. So what I'm trying to say is we're telling them what we need, because we know what we need, because we're the ones that's out there going to the houses, even though COVID has stopped us all from being able to do the face-to-face visit. We are doing them Zoom, we are doing them FaceTime, we're doing them just, a call. We have Zoom classes that we're providing. So we're trying to do the best that we can with our new normal and still keep everybody safe and sound. But if we're saying what we need and nobody's listening and we're the ones out here, how are we going to reach that accelerated infant mortality, preventing the infant mortality if nobody's listening? The people who makes the difference, the money people.
Thanks, Dee. I don't know, Dr. Warren, I don't want to step on toes if you had anything to say there. Okay. We had mentioned this at the beginning of the call, but we started right on time. And I know some of you came on late. We are sharing, this is specifically, it's great that there are others from outside of Region 5, and we see the national data, and there isn't a state that can't work on this. But this is specifically for Region 5, and we have the list of who's on this call, and we will be letting the state folks within those Region 5 states know who was on this call so that they can be connecting with you all. And it's great. What I've been hearing is a lot of the community. We have 5% community on here, and what I've been hearing are folks that are really in the community talking about the needs. And what I'm also hearing is that you're sharing stuff and it doesn't feel like it's being heard or you're not seeing. And that's something we talk about all the time, right? Is we need to make sure that we're communicating and partnering all the way, that not only are we hearing from you, but we're letting you know where that's going. What's the status, what's happening, what the barriers are. So thank you for sharing. You've got all the right people on this call, I think, to be hearing these things. And as Lynn has shared, there's a lot of information in the Q&A that we will be following up on because we are pretty much at time. We've got like a couple closing remarks. And so we're capturing what's in chat, what's in Q&A, and we will be following up with that. Dr. Warren, anything to say before Lynn closes out?
Just thank you all. It has been so exciting to see the questions that have popped up in the chat. I've been trying to answer some of them live as we've been going, and the questions that have been raised and have been answered by Denise and team. I appreciate also that you're asking difficult questions. If this were easy, the people who come before us would have figured this out, right? But what I don't want to do is for the colleagues who come after us to still be wrestling with this question. So I'm glad you're answering or asking those questions. I'm glad you're all here. We're committed to working with you on this. We're still figuring this out. What is this exactly going to, what's the what, right? What's this exactly going to look like? But a part of the goal of this is to hear from you what you need and how we as a bureau can support you and how we can work with state and local partners to further that work. So thank you. Thanks again to CityMatCH and all the folks on the planning committee for pulling this together.
Thanks, Dr. Warren. Lynn, I think Lynn's putting up some slides that she'll touch on, but Lynn, could you also put your email in the chat? Because what we've seen is some of you are here under somebody else's registration. So if you email us, we can make sure we capture you for the next round. So you get your own invitation.
Good point. Thank you, Denise. Everyone, I just put my email address in the chat box. So what you're seeing right now is our next step slide, and related to one of our next steps, you'll receive a follow-up email from me directly. So as you know, this series is a whole year-long series, and so we'll have information on the next webinar, including the link to register, and then we'll have a brief survey for you, including these same few questions that we discussed today, and then we'll share the recording of this webinar when it's available and the slides when they are available. So as you can see from my slide, the next webinar in this series is on March 23rd. And it's at 1:30 to 3:30 Central, 2:30 to 4:30 Eastern. And we're very, very excited to have Drs. Donald Warren and Dr. Art James, and they'll be co-presenting together to contextualize public health in US history. As we've talked about here today, you know, different sectors are involved in health disparities work, or at least ideally they would be, right? It's public health, it's education, it's housing, it's everybody. It's a concerted community effort. And we believe that it is important to know the history of how we came to be, how health disparities came to be, because from a systems perspective, health disparities are a manifestation of a system, right? And so if we need to address the health disparities, we need to understand the system as well. And so all of that will take place in March. That conversation will take place in March. And then in April, we don't have a firm date yet, but you can expect a presentation from Dr. Vijaya Hogan, who will take us through a conversation about equity work. And she'll talk a little bit about frameworks, the challenges of equity work, and then maybe some suggested measures for, you know, measuring your progress in equity. And so that information will be shared widely once it is available. And again, you can email me your information if you didn't register, if you received this Zoom call from somebody else. And then you can look forward to receiving a couple emails from me between now and March 23rd. So thank you everyone for joining, for spending an afternoon with us. And we really look forward to seeing you on our next call in March.
Thank you.